Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Now we're going to discuss the treatment of stage 3 and 4 Hodgkin's lymphoma. Pleasure being with Dr. Ann Moorwacher, Associate Professor of Medicine at University of Southern California. Thank you. Okay, so let's assume now a patient has had a biopsy of a lymph node which has come back positive for Hodgkin's, and they've had a PET scan or a CAT scan which shows disease above and below the diaphragm, and maybe even the bone marrow biopsy is positive for Hodgkin's. What happens for that patient?
Well, first, we generally do look over the PET scans ourselves and really evaluate whether that evidence is clear. Sometimes it's just not that clear, and the patient wants to know, well, don't you have to go in there and biopsy it or go into surgery to see that it's really there? And generally we don't pursue that, because for many of the reasonably good risk patients with stage 3 or 4, they're still going to be offered the same chemotherapy that a lower stage patient would be offered, which is ABVD. On the other hand, if we're really debating a change in chemotherapy, such as to the more intensive escalated Bleomycin regimen, we want to really recheck those areas. In particular, one of the obscure areas is if it involves the liver. It often doesn't cause any spots on the liver on CT scan, but it causes a slight enlargement, but doesn't look in any other way abnormal on the CAT scan, and that can be a bit of a quandary. You know, is that real involvement or not? Sometimes we're not sure about a site that we suspect on a PET or CT scan until after we've done the chemotherapy or partway into that we see on our next set of CAT scans that yes, the liver was enlarged and now it has gone back down in size, or the spleen was enlarged and is reduced in size, or that questionable spot went negative. Therefore, we are suspicious in retrospect that that was true stage 3 or 4 disease. Generally, the accuracy is pretty good, though, from the first staging tests. But there is a decision point, and there are other factors that come to bear there of the patient's age, their gender, some of their laboratory tests, their hemoglobin, and so forth, that would influence whether we think they're a very high-risk patient. If they have 4 or more of these 7-point factors, say, on this one scoring system, we might actually encourage them to think more strongly about the more intensive escalated Bleomycin regimen.
So there's 2 chemotherapy regimens. One is ABVD, one is the European Bleomycin. Would you just please explain what each one is? Let's talk about ABVD.
So ABVD is a 4-drug regimen typically used in stage 1, 2, and 3 Hodgkin's disease. It's sometimes used in stage 4 and has got a fairly good performance in that area. But if you add in the other additional risk factors, the chance of cure from that alone starts to drift down a little bit. So it's adriamycin, bleomycin, vinblastine, and DTIC, or dacarbazine. And those 4 drugs have been a very, very good performer as a regimen in Hodgkin's disease for cure, for frontline therapy. The Bleomycin regimen is quite a bit more elaborate, and incorporates other drugs such as etoposide and cytoxan, procarbazine, prednisone, that make for a much more intensive and very time-consuming regimen, more toxicities from those other drugs. But it is used, at least these days, more selectively for the very high-risk patients, patients who have a number of other factors that really reduce their chance of being cured by the ABVD regimen alone.
I see. So let's just go one at a time for our patients. Anthracyclines, what is the side effects that they should expect?
The main one we worry about medically is the risk for cardiac injury to the pump function of the heart. ABVD is given in split dosing, so that risk is relatively low compared to a patient who takes it for non-Hodgkin's lymphoma or breast cancer, where it's given at a lot larger dose at once. Also, our patients, on average, with Hodgkin's are younger, but we still use the ABVD regimen, and even our 72-year-olds. We just check their pump function by an echocardiogram or a MUGA scan before to make sure that they have solid pump function before they start. And if there were any problems while they were on treatment, we might recheck that. But in the younger patients, generally not much of a concern. It is one of the drugs, though, that makes the patient lose their hair. So they will gradually lose it on the ABVD regimen. They lose it more abruptly on other regimens that use the higher dose. It sometimes causes a little darkening of the nails. It contributes to some of the nausea, and usually more the delayed nausea of the ABVD regimen, although that's alone would be easily controllable or preventable. And it contributes quite a bit to the drop in blood counts that we see with each cycle of chemotherapy, the drop in the white blood cell counts particularly.
What about the bleomycin?
Bleomycin is a drug that isn't used in practically any other diseases currently except for testicular cancer and Hodgkin's disease. But it's a key drug that seems to be an important part of this regimen. It's a little notorious for sometimes causing inflammation of the lungs, often later in the therapy towards the last few cycles. And it sometimes causes fever and chills on the day of administration of the drug. So we do want to know, for example, if someone that was a heavy smoker, an older patient who maybe had smoked heavily throughout their life, we'll sometimes check a pulmonary function test before. Some centers feel that everybody should have a pulmonary function test before they start. Other centers do not. It's done more on a functional basis because extremely subtle changes in that are not necessarily going to prevent you from using that, because since it's part of the larger whole of the highly curative regimen. The fever and chills are sometimes a little bit annoying and not that frequent a side effect, but easily treated.
What about the vinblastine?
That's a drug of a class called vinca alkaloids. They're very well known for causing a little constipation. We ask patients to be ready for the day of chemo and be prepared for not coming in already constipated if they can. And over time, sometimes causes a little tingling in the fingertips. That's a reversible effect that goes away over time after they're done with the chemo.
I see. Now let's talk about the dose-escalated via COP. You said etoposide. What side effects can they potentially experience?
That's a little bit like the Bleomycin, a fairly potent drug, strong cytotoxic of the classic chemotherapies that kill cancer cells by damaging DNA. So like Bleomycin, less so, but etoposide does have some potential for causing secondary leukemias. It does cause a strong drop in the blood counts, especially if it's given with Bleomycin and other drugs. And will cause that drop in the white counts with each cycle. It'll contribute a little bit in general to the fatigue or nausea. By itself is not a difficult drug to manage, but it's given in combination with the whole regimen.
What about the Cytoxan? What is that?
That's also a very classic standard chemotherapy agents of that alkylator drug class. And we think between the etoposide and the alkylator Cytoxan, that in particular may contribute to the risk of acute leukemia or bone marrow failure called myelodysplastic syndrome that we sometimes see following this regimen. So that's why it's always a very careful choice when we have a Hodgkin's patient where we're debating ABVD versus escalated BIACOP. The BIACOP regimen is a little more potent, more difficult, but also carries this small risk of causing secondary leukemias, about 2% or so in the follow-up on the German trials. So it's a trade-off. You want to have a higher cure rate, but you may have a risk also from that chemotherapy that's a little higher than the other regimen that's a little gentler or easier to take.
Patients sometimes ask us, why can't we just surgically take the lymphoma out? What is your answer to that?
Good question. It's tempting, particularly when you hear there's a big lump in the middle of your chest, and in some patients that's where almost all their disease is. Why don't you just take it out? It's the nature of blood cancers that those cells are allowed to circulate. They're blood cells, and they wander off to other areas. Generally in Hodgkin's, they are somewhere in the nearby neighborhood, but they are certainly probably outside of the area that you see on CAT scans. So cutting them out does not cure the disease for the most part in this particular entity, and it introduces you to a big surgery that would take you quite a while to recover from, and you'd still need chemotherapy anyway. So you can sterilize that entire area with good quality chemotherapy regimens, and generally the surgery is not going to add anything to the cure rate, but add a lot of recovery time and pain and discomfort of recovering from the surgery.
Can patients work while they're receiving chemotherapy?
Absolutely. It is often a little challenging with ABVD because it's a moderately tiring regimen and it's very frequent. It's every 2 weeks. The patients who want to work on it, for example, are some of our, very commonly they're students that are busy in college with their course load. They'll often arrange for their ABVD to be on a Friday because they feel a little off on the first 2 days after the ABVD. But it is a cumulatively somewhat tiring regimen, and if a student just started a semester and still has time to do so, we'll often ask if they want to just take a break that semester and take their chemo and just focus on that. Or if they're a grad student where their advisor can give them a little extra time and they can maybe run their projects out a little further into the summer after that year. It is a little tiring. It's a little challenging for their concentration on intellectual work. They can do it, but it'd be like working with a chronic cold. It sort of takes some of your energy and focus away. But I have had patients who worked and went to school through it.
Very nice. What do you tell your patients regarding fertility preservations?
Well, this is where the choice of regimen is very much a key issue. The ABVD regimen does not appear to affect fertility very significantly. In fact, as I've mentioned, it's very important not to get pregnant while on it. It doesn't affect fertility to the point where I want people to be more cautious and not forget to use birth control. They're in the middle of chemo. It's not a good idea to get pregnant in that setting. The periods often stop in women towards the later end of it, sometimes not at all, but it's slowing down the growth rate of the uterine lining.
Yeah.
On the other hand, the Biocop regimen is a whole nother matter. That regimen does cause infertility in the majority of males and probably a large proportion of females, but that would be a little more age dependent. The alkylators would affect the ovaries like they do in other chemo regimens. A younger woman's ovaries would probably withstand it a little more than a middle-aged woman would.
I see. So what about sexual relations? Is that appropriate during chemotherapy?
It's certainly allowed. It's not contraindicated when people are on chemotherapy. They're often a little tired. It's not their first thing they're thinking of. But we do pay a little attention if their white counts are exceptionally low. We might want to check that during that part of the cycle, because we check it in general just to see if they're getting ready, if they're ready to start their next chemotherapy. Maybe we'd ask them to use a condom or something, or just be a little careful during that time period. But overall, it's not much influence on that.
How do you deal with depression in your patients who have stage 3 or 4 disease?
Well, it's a combination of depression and anxiety, and I see sort of two different phases of it. A lot of patients are, of course, very shocked by the news, as they would be with any cancer, and even it's a little paradoxical that everyone's trying to be encouraging, like in the movie 50-50, they said, wow, that means you have a 50% chance of being fine.
Right.
You know, that doesn't sound good to a patient who never expected to have cancer in the first place, particularly a young person. But there's this sort of acute anxiety or worry about their future, which we tend to be very pragmatic about, that, you know, we have plenty to do for this disease. We have very high expectations, and we're aiming for cure, not just a remission. So we really try to sort of emphasize that a bit, but not whitewash it too much. It's still cancer, and it's still chemo. And it's very disruptive to their life. You know, they had their plans, they were applying for professional school, or they were starting college, or they were getting married, and this is suddenly in the middle of it all. No one expects to deal with this, particularly the younger patients. On the other hand, I think the support of their family and their loved ones is important. I think sometimes finding someone else of their age group that's been through this or something like it is very helpful. There aren't a lot of support groups just for younger individuals, and not all Hodgkin's patients are young, so just sometimes meeting someone who's a little more like them. If I have a 70-year-old Hodgkin's patient, maybe they'd like to meet or talk to somebody who's gone through that. The older patients tend to feel that they can take their support from people. They've had other friends who've had cancer, and depending on whether they saw that as something that came out with a positive outcome, the downside of that is they may have had a lot of friends who had cancers that were much worse prognosis than theirs, and that worries them, and they're focusing on that. In general, I think that younger individuals are more, I think, positive and encouraging. Their friends are more positive and encouraging, and not running up to them and telling them every horror story, because they haven't known very many people with cancer.
Right.
I think there's a second phase of depression and anxiety that happens after chemo is done. They've been very gung-ho. There's a real busy schedule with chemotherapy. They've been very focused on getting their labs checked, getting their chemo, taking care of business, just sort of tired, getting through it. And then afterwards, there's this sudden free time that some of them, I think, almost have a post-traumatic stress type response to. They feel like, I'm not doing anything right now but waiting to see if this disease is going to come back. And that actually makes them sometimes more anxious at that phase, that they've got more time to think about it and nothing's going on. And again, just trying to say that's a fairly normal feeling to have at that time. We're going to be checking on you, and I'm helping watch you, and I'm going to check your lymph nodes, you know, very often, and you can always run in if you feel something funny and you want me to check it out. Don't sit there at home and wait 2 weeks for the next appointment. And that sometimes helps keep their anxiety under control, and it tends to fade with time as they get further out and the next PET scan looks good. I also tell them not to schedule their PET scans too far before my appointment. Our PET scan group will read it within a day or two, and if they do it a week ahead, they sit and don't sleep all week.
Right, exactly.
So don't do it too far ahead so you sit and suffer there. Just do it right before, and we can look at those results right away.
I see. Our patients often like to take alternative herbal medicines to maintain some sort of control. What is your stance on that?
Well, try not to be, confrontational about that, but we do think there is a potential for some alternative meds or antioxidants to actually interfere with how the chemo works. Your body has to process those things, your liver has to process those things, and antioxidants might actually interfere slightly with how the chemo works, specifically by creating free radicals in the cancer cells. So I ask people to just take a break from that while they're on chemotherapy. I don't try to say, don't ever touch that. I just feel that we don't know. And there is a little bit of fringe evidence that there's some counterproductive aspects of taking things in addition to the chemotherapy that might be not helpful. But if you're too judgmental about it or too discouraging, people do things and not tell you. And I think that's a worse situation than just admitting, that maybe we disagree on this point, but I do try to strongly encourage them to just take a break from that until they're done with chemotherapy.
I see. How do you deal with nausea and vomiting associated with chemotherapy?
That's a little bit of a challenge with the ABVD regimen, in particular. The standard drugs that work perfectly in most of our other regimens, such as the ones for non-Hodgkin's lymphoma, aren't always completely effective in ABVD, the standard pill-based Zofran or Kytril and so on. There's often a little bit of delayed nausea with ABVD where people feel a little sick 2 days afterwards. Sometimes it's just queasiness and they just don't eat that much on that day, and no one usually loses weight on the regimen. They make up for it later. But so we'll sometimes have to go into some of the fancier, more expensive anti-nausea drugs that last a little longer and cover the delayed nausea. Usually, their first cycle or two or dose or two goes well, and they're starting to notice they should be very careful to tell the doctor, because we have to add some of those drugs on the day of chemotherapy for them to protect them against that nausea that happens 2 days later. We also usually send them home with a little regimen of things they can take and encourage them to take them sort of on a schedule sometimes, instead of waiting till they're really nauseated and then they can't swallow a pill. Some patients will ask about marijuana. And we tell them, first of all, there's a prescription form with the active ingredient of that. I don't think it's really that great an anti-nausea agent, but I ask them not to smoke, because that smoke may interact with the bleomycin, and that may be an issue for their lungs.
I see.
I think we've got good enough other anti-nausea drugs that it shouldn't be that critical to go that route.
Is there any diet that would lessen the vomiting after chemotherapy, or no?
Most folks just eat very lightly if they're having the nausea. They don't lose weight on these regimens usually, so it's not usually going to have impact all throughout the cycle. It's just a day or two that they don't feel like eating that much, and they eat very lightly, sort of simple things.
There is a very important biologic medicine called Rituximab. Is there any subtype of Hodgkin's you would use it for?
Well, there is a particular subtype, the lymphocyte predominant type, which is generally a less aggressive Hodgkin's. It's more, biologically, it resembles more a low-grade lymphoma, and often is a very limited stage. Actually, I had a patient recently who had a stage 4 case, and it's hard to find much literature on it, because they commonly have a very limited amount of disease. It's not very aggressive, but it can be persistent and come back even after transplants or full chemo. And that distinction is that the cells in the mix of the lymph node are more fully involved with these small lymphocytes, or type of cell from the immune system, and they mark with a marker called CD20. Rituxan is an antibody that was developed to target that, to help the immune system attack the cells. And it's used very successfully in non-Hodgkin's lymphoma, and it looks fairly active in the nodular predominant type Hodgkin's disease. But whether it's really better than the chemotherapy or should be added to the chemotherapy is still a little bit of the ongoing debate. And I have some patients who, for example, have hepatitis B and they can't take the antibody. There are some contraindications to that. That's why we usually check at the beginning of our workup of a patient with Hodgkin's and most of our other blood cancers. We check for hepatitis B and C and HIV because that would influence some of the management of the disease, not necessarily the primary chemotherapy, but we have to watch out for other complications if they have those, and we do have to avoid Rituxan, for example, in someone who has very active hepatitis B.
I see. So let's say someone's completed treatment. How do you follow them after that?
Well, this was a subject of discussion yesterday. Historically, or traditionally, we follow people with physical exams, relatively ordinary blood tests. There isn't really a unique blood test or marker of Hodgkin's disease. and physical exams for the lymph nodes, and then CAT scans at certain intervals. So the physical exams are more frequent. You can do plain blood tests and physical exams, every month or two in the first few months after the chemotherapy. You're usually doing that during each month while you're on chemotherapy. And then you start sort of spreading it out to less frequent intervals as you get further out, maybe to 3 months or quarterly in the later part of that first year and the second year, and maybe 6 months after that. Different people, different groups do differently, but they did have a sort of panel discussion of that yesterday at our meeting. And what's changing is that in the past, people used to do CAT scans every 6 months out to even 5 years. And then they started dropping it back to 6 months in the first year only, and then dropping to once a year for 5 years. And now more recently, it's really come into question whether that has any importance at all. They found that there is only about 29% of patients whose relapse of their Hodgkin's is even picked up by the doctor by physical exam or CAT scan. 3/4 of the patients, they notice something, and it could be in between very scheduled regular checkups or CAT scans. And there's no evidence that finding it a little bit earlier by CAT scan will change the ultimate outcome. They're still very successfully treated whenever it's found. Our temptation, I think, is to check a little more carefully in a patient with higher risk disease. I think most of us would still want a CAT scan or two after therapy in a high risk patient, but maybe in a very large proportion of our patients are fairly good risk. Maybe those CAT scans we were routinely doing after the end of therapy are not really adding much, except they are exposing folks to a little bit of radiation. And that's even an issue with PET scans. Some patients would feel more secure continuing to have PET scans, and they want to keep checking, and the PET scan they know is more sensitive. But it also increases the radiation exposure. And they really haven't found it has much predictive or diagnostic value once it's gone negative to keep doing them. So we've also pulled back from doing that in recent years.
I see. So let's say, God forbid, a patient does relapse at some point. What happens to that patient?
Generally, relapse, at least historically, used to have slightly different prognostic indication if they relapsed early, within a few months after the end of their chemotherapy, or if they had relapsed a year or 3 or 4 years later. It gets less common, of course, as you get out in that range. Clearly, it's a little more aggressive if it relapses in a few months, but the treatments generally are pretty much the same unless the patient is very elderly. We're going to recommend that they take a salvage chemotherapy and then go into a very intensive chemotherapy in association with a stem cell transplant. So the salvage chemotherapy traditionally has been ESHAP. People are starting to use ICE a little more frequently now. Very similar regimens, a short inpatient stay in the hospital to receive them. They're a little more intensive, medically at least, than ABVD. And we then look again with CAT scan or PET scan to see that the disease is coming under control, that the PET scan's going clear, and then collect stem cells from the peripheral blood. So what used to be called a bone marrow transplant is generally done with peripheral blood cells now. And then bring them into an inpatient stay where they receive basically a mega cycle of chemotherapy. It's a very intensified dose of chemotherapy that would be like the equivalent of 6 or 10 times the normal doses of chemotherapy, picking drugs that mostly affect the blood system so that you can rescue the blood system with the stem cells you saved from the patient ahead of time. So it's generally an autologous stem cell transplant. That's the predominant type used in Hodgkin's disease. This is not a disease that is generally going to be circulating in the blood or even that commonly in the bone marrow, so it's fairly safe to use the patient's own blood cells for the transplant. And the outcomes are very good. They're in the 70% cure range for the sort of standard risk patients going to transplant.
I see. So when we mention, transplant to patients, they think of surgery. But actually, that's not the case.
There's nothing really transplanted. It's their own cells, and technically the correct term for the whole procedure is high-dose chemotherapy with autologous peripheral blood stem cell support. But that is too much of a mouthful to say, and everyone seems vaguely familiar with the bone marrow transplant. It's even a misnomer in some ways to call it a bone marrow transplant. We're not usually using bone marrow, although those cells are going back to the bone marrow. And it's only a transfer of your own cells. It's not really a transplant from somebody else.
Exactly. So they would basically give some blood, and then they would give their own blood back. That's all a transplant.
The collection's a little more elaborate. If they know anyone who's donated platelets at the Red Cross, it's a machine where blood goes out one arm from the donor, and it's spun in a machine like a top-loading washing machine that separates the white cells, platelets, and red cells. And in the case of when I donated platelets, for example, they took off the platelets, but if a patient's donating white cells for themselves, for their own transplant, or if they're a donor for someone else, for leukemia, for example, for an allogeneic transplant, they pull off the white blood cells, they're saved in a little transfusion bag, and the rest of the blood goes back in the other arm. In a donor, a normal donor who's donating that way. A patient for themselves is usually getting ready for transplant. They'll have a special line put in that has two lines so that they can do it comfortably and for longer hours. It'd be very hard to sit still and do this 5-hour collection. Sometimes it takes multiple days to collect the cells. Not that uncomfortable, it's just a little time consuming.
I see. There's a medicine called Brentuximab. When do you use that?
That's been an exciting new development, just recently FDA approved. This is a new sort of concept of, we mentioned antibodies before, Rituximab. Antibodies are the proteins we normally make to sort of tag strep throat bacteria and so on to alert the immune system to attack that organisms. We can now create antibodies against targets we want to design them against in human cancers, and they've been very successful in the blood cancers, the most successful in blood cancers. But there's sometimes limitations of you can target a cell, but the antibody itself doesn't kill the cell. It has to bring in the immune system, and some patients' immune systems won't particularly react to those antibodies in a way that's helpful enough, and we think Hodgkin's disease itself may interfere a little bit with normal immune response. So they developed antibodies against a target called CD30, which is seen on virtually all Hodgkin cells, and it's seen on another type of lymphoma. And they added a drug to the antibody. So the antibody is now acting like a magic bullet. It goes and attaches to that target and delivers the toxin right to the cell, instead of exposing the whole body to that chemotherapy agent. And so that's what we call antibody drug conjugate. And there's quite a bit of interest in developing other ones. This one has been extremely successful in the trials and works against this other type of lymphoma that is also CD30 positive, extremely high response rates, also in Hodgkin's. Just a caution though, people tend to sometimes hear about the new thing and think that would be better than chemo. It isn't necessarily better than chemo either in efficacy or side effects. There are still side effects. A little bit of that chemo drug still gets in the system a little bit and can cause some neuropathy or tingling of the fingers, and there's still side effects like there would be with any chemo agent, just a little different. But the concept of it is very, very exciting. It's a model in which other drugs will be developed, but it is also very successful just as a straight agent. Now, until it gets tested up front, that will probably only be reserved right now. Its approval indication is for patients who've relapsed after transplant. That is because that's their first indication they pursued for permission with the FDA. But as that drug looks very successful, we'll no doubt see that they're going to incorporate it into higher risk regimens and earlier in treatment. And if it looks safe and acceptable and very effective in those settings, maybe it'll replace one of the annoying drugs in ABVD.
Exactly.
And that would be, I think, what a lot of us are hoping in the future. Maybe you can take out one of the really irritating drugs in ABVD and put this one in. Maybe it'd be a little easier, gentler, and as or more effective.
Very nice. What is a clinical trial, and do you recommend that for your patients?
In Hodgkin's, we're in an interesting, good position where we're so successful with the disease, we have to be a little careful not to mess with success. So there have been trials, and we do certainly encourage patients to participate in them, but generally the frontline trials, at the moment, they've sort of settled, I guess you could say. The consensus is predominantly that ABVD is the standard drug regimen. But if patients have unusual risk features, there will be trials out there that will incorporate, say, Brentuximab, or they have used other regimens in the past, or they'll look at using a PET scan after 2 cycles to determine if a patient should change therapy or maybe add an agent. You know, the current hot topic would be Brentuximab, but it could be another new agent that's, invented next year, and see if you can bring that patient's response rate back into normal range, into optimal range, or to PET scan negativity with that addition. So some of the trials will start out with the standard therapy and then have a decision point in them to add an agent. Other ones will take just high-risk patients and say, let's add something from the beginning to see if that'll influence the outcome or your chance of relapse. It takes very large trials, though, because we're very successful in the treatment of Hodgkin's. So we're literally quibbling between 90% and 95% cure rates, and sometimes it takes 1,000 patients to do that study, and that's why many of these studies are done in Europe, where they have the whole country's population base to answer these questions. In the United States, we do that through intergroup trials. Once a patient's relapsed, particularly if it's after transplant, there are trials. That's how Brentuximab was developed and tested, for example. But it is not a very common scenario. Not too many people would get to the point where they've relapsed not only after first-line therapy, but after transplant. So it takes a while to find a study. There aren't usually a lot open, even nationally. We'd have people flying in from other states when we had a trial that included Hodgkin's patients, because there are not that many that relapse, thank goodness.
Right. What about the scenario in which family does not want you to tell the patient about the diagnosis or prognosis? How do you handle that situation?
Well, in Hodgkin's, generally these are young adults, and we do have an obligation as a physician to deal with them as an adult, and also even conversely, parents often come in and want to be protectors, forgetting that their child is actually 21 years old and is legally capable of making decisions for themselves, so they want to be helpful, but it's actually not their right to interfere with that primary relationship with the doctor and patient. So I usually will take that patient aside and ask them, and you realize I'm happy to sort of deal with you alone or you with your parent, but you need to tell me, and maybe they're not sure in the beginning how much control they want to have over the discussions and the information. But even patients who are middle-aged and older sometimes are, I'm overwhelmed by having this diagnosis. Why don't you tell all the nitty-gritty stuff to my spouse or my brother or my mom or my dad, and just tell me what I need to do. And you sort of try to get a sense of that within the first meeting or two of a patient. Some of them really want to know all the data, want to go look it up on the web and want to read all the books themselves, and others are, I'm going to let my family member take on that project and take charge of scheduling my visits and just telling me where I need to be. I'll just deal with the disease. And that's a very reasonable approach too. I think sometimes there's too much information, TMI, and it's too much to take at once. And sometimes when we're trying to be helpful as physicians, we sort of, that very first meeting, we just tell them, everything there is to know about their disease and what we need to do, and it is a little overwhelming. I sometimes encourage people to tape record it, or we give the books or the information, or refer them to your to your videos, to just go back over it when they're a little less overwhelmed by it all, or let their family member do it, or their friend.
Wow, that's great. Thank you so much. Thank you for watching. We hope this has been educational for you.